Şu an saat bakıyorum 8:10 var. 8:30 gibi bitirmemiz lazım. Diğer konuşmacılara da zaman kalsın diye çok hızlıca toparlamaya çalışacağım. Planımda önce oksidatif stresten biraz bahsetmek istiyorum. Daha sonra
I will talk about oxidative stress, and then I will talk about the place of oxidative stress in the treatment, and then I will talk about the changes in the oxidative stress parameters. I will divide that into two groups. First, I'll talk about preclinical studies, and then I'll talk about the clinical studies, and we'll try to end up with the results. I have 29 slides, so I'll try to be very fast. Oxidative stress, in fact, is excessive exposure to oxidants and or reduction in the capacity of antioxidants. This is how we can define the oxidative stress. Free radicals are produced abundantly in mitochondrial, endoplasmic reticulum, and nuclear electron transport systems. And during normal metabolic events, we see plenty of free radicals being produced. And the production of those free radicals might exceed the antioxidant capacity. When this is the case, the oxidative stress directly has an effect on lipids, carbohydrates, and proteins negatively, and the cell is negatively affected by this. This is one of the established definitions in this area. There are numerous defense mechanisms in the body which prevent the formation of free radicals. Let's have a look at those. Here you see the oxygen radical, and it combines with nitrogen, and then you see another formation which follows this. Superoxide dismutase and hydrogen compounds are formed, and together with the combination of those nitrogen radicals, and the other one is combined, and a serious amount of oxygen radical and nitrogen radicals are released. As a result of this, we see peroxidation. We see a process which shows its effect through peroxidation. The lipids are plenty in the cellular membrane or intracellular membrane. Therefore, you see some sort of an impairment in the viscosity and permeability there. Therefore, you can see problems in the cellular wall, and the oxidative stress's secondary form can be observed. And then via the proteins and nitration, we see the enzymes and the other proteins being impaired. Proteins are plenty in many parts of the body, so this becomes quite problematic, and it has a negative effect on DNA and RNA. Serious effects are seen through DNA and RNA, and very complicated events might occur. The antioxidants which are found in our body are catalase, tocopherol, glutathione peroxidase. Among the oxidants, we have hydroxyl radical, peroxyl are the ones that we know a lot in the cellular impairment of the bipolar disorder. Hydrogen peroxide is also another example for that. In bipolar disorder, what is the position of oxidative stress? About the place of oxidative stress, many trials have been carried out, not only for psychiatric disorders, but also for the other disorders. The same issue has been looked into in almost 90 diseases. The pathogenesis might play a very important role. In psychiatric disorders, oxidative stress plays a very important role, as I said before, like schizophrenia, depression, anxiety disorders, and adult attention deficits. In psychiatry, we see those problems. During the episodes under remission, we see that oxidative stress increases and antioxidant capacity is somehow impaired, according to various trials. Oxidative stress is related to psychiatric diseases, and this is something which is not surprising, because due to use of excessive oxygen, cells and organs are subject to oxidative stress. It bears a significant amount of lipid in its structure and also some metals. Therefore, we can talk about a serious amount of oxidative stress, and this is not something surprising. And the issue which I'm going to talk about will actually be the studies examining the parameters of oxidative stress in the treatment of bipolar disorder. And those studies can be divided into two groups, preclinical studies and clinical studies. First, I want to talk about the preclinical studies, then I will finish up with the clinical trials. Preclinical trials are many in number, but I'm going to talk about only 9 of them. Maybe other trials are also available, but the first study was carried out in 2003 by Wang and his colleagues. And lipids peroxidation and protein oxidation are prevented in rats' brain cell cultures which are exposed to oxidative stress. This is after 7 days of treatment with valproate. I mean, after administering the valproate, the stress is somehow prevented and reduced in amount. And then Valmasuri in 2008 has come up with a mania model and worked on rats and he worked on a combination of both drugs, both on mania model created with the amphetamine on Wister rats. As a result, he showed that protein damage was prevented in the rats which were given NAC and DFX and their combination. In 2009, another trial was carried out. As a result of trials conducted with lithium and valproate, it was seen that the efficient agents like lamotrigine and the other one like olanzapine were looked at in terms of their efficacy, and as a result it was shown that glutathione S-transferase M1 protein levels and GCT enzyme activity, which are among the main antioxidant mechanisms in the brain, are actually increased in the treated rats. They have a higher activity. So oxidative stress amount and parameters have significantly reduced in this trial, and olanzapine is treating those rats. And this is a study from the perspective of oxidative stress. Another trial in 2009 found that cannabidiol treatments, it's an antioxidant by the way, it increased the level of BDNF and prevented protein damage related with oxidative stress in an animal model of mania induced by the amphetamine, although there were no changes in mobility after treatment. And cannabidiol treatment is preventive in terms of mania according to this trial, specifically for the rats. And in addition to that, BDNF levels increased, and it might have, and the authors say that it might have a neuroprotective effect. In 2010, a mania model formed in combination by Obane was conducted, and it was shown that lithium and valproate treatment prevented and improved the oxidative damage in Obane-induced mania model of rats. And in addition to that, superoxide dismutase levels increased, but catalase levels were shown to be decreased. Superoxide dismutase increase and catalase level decrease is actually showing that in this model composed by Obane, there is a certain amount of oxidative stress as well. In 2010, a group of rats were given folic acid, and another group was administered lithium. The rats were divided into 2 categories, and then a mini model formed by Obane showed that there is no mania-like status in the rats. But in addition, an increase in thiobarbitric acid level and a decrease in glutathione peroxidase level were observed in hippocampuses of those rats. This is one of the most important stress parameters, oxidative stress parameters. So it does not trigger the mania model, but also causes a reduction in the antioxidant capacity. In 2012, the Rosa has conducted a study in which a mania model was induced with methamphetamine, and there were three groups. One group took lithium, the other group took valproic acid, and the last group took saline. They found that oxidative stress generated by methamphetamine were prevented and improved after prophylactic treatment with lithium and valproic acid. In addition, manic-like picture has not appeared in both treatment groups. They stated that these results may be related with the amphetamine dose and the location where it was applied. Machado and his colleagues in 2013 have conducted another study where they used lisdexamfetamine dimethylate in rats. Mania-like status did not appear in rats which were treated with prophylactic lithium compared to those treated with saline. They also found reduction and improvement of oxidative parameters, especially in the prefrontal cortex and striatum. And the last study is from Steckert. It was conducted in 2013 again, and in a mania model, the rats were divided into two groups. Histone diastase inhibitor was given to one group, and the other group took saline. The other group took only saline for 14 days, and then rats were treated with both sodium butyrate and saline for another 8 to 18 days. As a result, oxidative stress were improved in the prefrontal cortex, amygdala, hippocampus, and striatum of the rats, and it took and it was also a mania-like picture that disappeared. Clinical studies. I would like to make a summary of the clinical studies now. The first study was conducted in 2007 by Frey and his colleagues, where they compared bipolar disorder type 1 patients in manic episode with a healthy control in terms of oxidative parameters. One of the patients were treated by hospitalization, but the other one did not want to be hospitalized. The hospitalized patients, after a 6-month treatment, had normal levels in the blood, but the catalase did not change at all. Normalization of these levels were not observed in the patient who refused the treatment. On the contrary, they were using a healthy control group. This actually is a trial conducted by 3 patients. And in fact, the Brazilian group carried out another study where they used the oxidative stress as a factor. Machado Vieira and his colleagues in 2007 have conducted this trial after the previous one. They compared 30 patients who were not treated and 15 lithium-treated bipolar disorder patients during their first manic episode with 30 healthy controls in terms of thiobarbiturate acid, superoxide dismutase, and catalase levels. 30 healthy controls, and the others were compared with one another in thiobarbiturate acid, and COD and CAT levels. So it was found that the levels were higher in patients who did not receive treatment than controls. It is an oxidative parameter, therefore an oxidative parameter elevation is seen in those patients, which means there's an oxidative stress there. SOD and CAT levels are actually showing antioxidant capacity, so there is a compensation mechanism here. The antioxidant capacity, or the substances which are trying to eliminate the problem, are increasing in the manic patients who are not receiving any treatment. In the same study, it was reported that lithium caused a decrease in TBARS level. which means oxidative stress somehow disappeared, and superoxide dismutase and catalase ratio also went down. This shows that oxidative stress is still continuing because there is no significant improvement in catalase according to this trial. As a result, authors suggested that even in the first manic episode, oxidative parameters can increase and cause an activation of antioxidative mechanisms. This is how the trial was interpreted by the authors after those results. In 2007, Ana Cristina Andreas from Brazil conducted a clinical study and compared 32 bipolar disorder patients. They were followed in outpatient clinic with the same number of healthy controls. They're not very active. They're followed up in an outpatient basis, but they're not rhythmical as well. DNA damage was compared between those groups. As a result, DNA damage was found to be higher in bipolar disorder patients who were treated in outpatient clinic. They also stated that this damage was correlated with the severity of manic and depressive symptoms. If there are signs of depression or mania, DNA damage was found to be much higher according to this trial. This is from Turkey, a trial from Black Sea Technical University in 2007. This is a very complicated trial. In fact, 15 bipolar disorder patients were treated with lithium and olanzapine in the first 6 months and with lithium monotherapy in the following 6 months. And before the treatment, lipid profiles were noted down. And after the trial was over, they noted down the lipid profile, TBAR, SOD, CAT, and GPX levels, and they looked at the changes. As a result, TBARS level were found to be decreased after both treatment protocols. Antioxidative enzyme levels were decreased after both treatments, but total antioxidative capacity was increased, related solely with lithium. Because after starting the treatment with a mood stabilizer, in the long run, antipsychotic levels have to be tapered in patients. They did the same thing. For 6 months, they used lithium and olanzapine, and then olanzapine was discontinued, and they continued with lithium. With lithium and olanzapine treatment, they saw that there was a significant decrease in TBARS, but with the discontinuation of olanzapine and continuation of lithium, the same reduction continued to take place. The antioxidative enzyme levels were decreased after both treatments, but total antioxidative capacity were increased, related solely with lithium. As I said before, lithium and olanzapine treatment, while going hand in hand with one another, this did not occur, but when the lithium monotherapy started, the total antioxidative capacity increased. The preclinical studies before were showing that lithium could have been neuroprotective. This is also supporting the same idea. In the first 6 months, the patients continued to use lithium, which means, in fact, this affects coming at a later stage, and the changes in catalase coming at a later stage are also important factors to take into account. This is from Antep, from Salih Selek in 2008. As far as I know, the first bipolar depression and oxidative stress parameters were looked into in this trial for the first time. 30 healthy controls, according to their SOD and NO levels, were accepted to the study. Blood samples were collected in the first and 30th day of treatment, and it was seen that in the first day, that is right before the treatment, the oxidative stress, the nitric oxide levels were higher and SOD levels were lower in patients when compared to the control group. And after treatment, it was found that nitric oxide level returned to normal, but returning to normal means that it is almost at the same level with healthy controls. However, SOD level increased and it still remained lower than that of the healthy controls. Kairova and his colleagues have conducted a very interesting trial in 2013. 10 healthy volunteers who were treated with therapeutic doses for 2 to 4 weeks were chosen as the study group. Lithium treatment was given and oxidative stress parameters before and after the treatment were looked at. As a result of lithium use, the SOD levels were found to be higher, which means antioxidant capacity was higher. SOD and CAT ratio were found to be lower on the other hand. This means, yes, there is an increase, but oxidative stress is still there. The level being low also means that oxidative stress is still present. So TBARS and CAT levels are not different at all in those healthy controls. This is a study from India. Sashi Banerjee conducted this study. 73 bipolar disorder patients were chosen for this trial. 48 of them were treated with lithium and 25 were not treated at all, and they were compared to 35 healthy controls. As a result, TBARS level were found to be higher in all bipolar disorder patients when compared to controls. There is oxidative stress in those patients, and the same result was observed in both patients who received and did not receive any lithium, which means that in patients using lithium, TBARS when compared to the group which is not using any lithium at all is found to be lower. So we can talk about a neuroprotective effect. And this is my last slide. Almost 16 studies were included in my summary, but as a result we can say we still need new trials. Oxidative stress is involved in many diseases of today, but it's not a very specific marker, and it's an area which is not very clear. And when we look into the literature, we see that different processes, different periods of the patients are not covered with different trials. Oxidative stress parameters of a patient might be going to different directions, but we do not know what direction this is. If oxidative stress parameter changes of the first-degree relatives of the bipolar disorder patients are looked at, it might be a very good approach, and possible neuroprotective effects of lithium and valproate via these pathways can also be studied, and the main results of the studies show that with the treatments, antioxidant capacity increases and the oxidative stress parameters decrease, and valproate and lithium might have a protective effect in this sense. Thank you very much for your patience.